Welcome back to the deep dive. Now, if you're a regular listener, you know the drill. We usually take a huge stack of articles, tech, history, economics, and we try to boil them down into something you can digest over a coffee.
But not today.
No, today feels a bit different. The vibe is a little more, well, a little more sterile.
It is. We're definitely trading the coffee shop for the operating theater. We're putting on the scrubs.
Exactly. We're trying out a new format here, something designed specifically as a revision tool. We're really thinking about medical students, surgical aspirants, or honestly, just anyone who's super curious about how the machine inside them actually works.
And we're going straight to the source for this one.
We are dissecting Chapter 70 of Baily and Love's Short Practice of Surgery, the 28th edition. The short practice that's, a few thousand pages long?
Medical irony at its finest.
It really is. And our topic today is the spleen. I have to admit, before I read this chapter, the spleen was just, that purple thing on the left that you really hope doesn't burst. It feels like the mystery box of the abdomen.
That is a perfect description. It really is the organ of mystery. It's often forgotten, just sitting there quietly under the ribs doing its job until one of two things happens.
Which are?
It either bleeds catastrophically or it gets absolutely massive. And when that happens, suddenly it's the only thing in the room that matters.
So before we slice into the anatomy and the trauma grades, we need to set some ground rules. This is a medical text. We have to be responsible.
Right, and I want to be crystal clear about this. This conversation is an interpretation. Think of this as a ready reckoner or a high-yield audio companion.
So this is not just us reading the textbook to you.
Absolutely not.
Mm-hmm.
This is not a regurgitation of the book. I am not going to read you the fine print on, molecular biology. You, the listener, you must read Chapter 70. You've got to look at the diagrams, the CT scans, all of it.
So what's our job here today, then?
Our mission is to build the coat rack in your mind. We're going to give you the mental anchors, the metaphors, the framework, so that when you do sit down with that dense chapter, the information has a hook to hang on. We just want to make it stick.
I love that. We're building the coat rack. Okay, so let's lay out the roadmap. We're starting with anatomy, the spleen's handshake with its neighbors.
Then physiology, the five-function factory.
Then we get into the high adrenaline stuff, trauma, how to grade it and how we treat it.
We'll cover pathology, why it gets so big, and then finish with the really critical post-op care.
Yeah.
Because taking the spleen out is, it's only half the battle.
There's a silent killer on the other side.
There is. It's a full itinerary.
All right, let's get into it. Section 1, anatomy. The geography of the left upper quadrant. Where does this thing even come from?
To really get the spleen, you have to go all the way back to the beginning. Embryology. So most of the gut, the stomach, the intestine, that comes from the endoderm, the gut tube.
But not the spleen.
The spleen is different. It's an outsider. It develops from these little condensations of mesoderm.
Mesoderm, okay. And where does that happen?
It happens in something called the dorsal mesogastrium. Now just picture the early fetus. You've got the stomach, and there's this sheet of tissue holding it to the back wall of the body. That's the dorsal mesogastrium. The spleen just starts to grow right in the middle of that sheet.
So it's not like butting off the stomach or anything?
No, it just appears in the wall. I want you to use a visual anchor here. Imagine a big empty room, and there's a curtain hanging from the ceiling, dividing the front from the back.
Okay, got it. A curtain.
The spleen is like a brick wall that suddenly gets built inside the thickness of that curtain.
A brick wall inside the curtain. Okay, I'm with you.
And because it grows there, it splits that curtain into two separate sheets.
Mm-hmm.
The front part, connecting the spleen to the stomach, that becomes the gastrosplenic ligament.
And the back part?
The sheet connecting the spleen to the back wall, specifically to the kidney, that becomes the lenorenal ligament.
Leno for spleen, renal for kidney. Makes sense.
And understanding those two ligaments, that is the holy grail of splenic surgery. The spleen is just hanging there, suspended by these apron strings.
Okay, before we get to the surgical nightmares hiding in those strings, let's talk numbers. Med students love a good rule. What are the stats?
Well, there's the classic 1, 3, 5, 7, 9, 11 rule. It's 1 by 3 by 5 inches, weighs 7 ounces, and lies between the 9th and 11th ribs. But Baily and Love, the 28th edition, they get a bit more metric.
What do they say?
They say the normal adult spleen weighs between 75 and 250 grams.
And in centimeters?
It's about 10 by 7 by 3 centimeters. But honestly, the numbers aren't as important as its position. It's tucked way up under the rib cage along the 10th rib.
It's hiding.
It really is. It's protected. And there's this one feature about its shape, a notched upper border.
And that notch is important, right, for diagnosis.
Crucially important. If you're examining a patient's abdomen and you feel a mass on the left, you're thinking, is this a huge kidney? A tumor? The spleen? You can feel a sharp notched edge on it.
It's the spleen.
It's the spleen. That notch is actually a remnant from when it was separate little lobules in the fetus that all fused together.
So here's the catch, though. In a healthy person, you or me, can I feel my spleen?
No way. Absolutely not. If you can feel that notch on a physical exam, that spleen is already at least 2, maybe 3 times its normal size.
So a palpable spleen is a pathological spleen.
By definition. We call it splenomegaly. It's a great anchor to remember. If you can feel it, it's too big.
Okay, let's go back to those ligaments you mentioned, the gastrosplenic and the leonorenal. You called them apron strings, but reading the chapter, they sound more like tripwire.
No, they are absolutely tripwires.
Yeah.
Let's take the front one first, the gastrosplenic ligament. It connects the spleen to the greater curve of the stomach. Now, why does a surgeon care?
I'm guessing there's something important inside.
There is. The short gastric vessels.
The short gastrics, they supply the stomach.
The very top part, the fundus. So imagine you're doing a gastrectomy, removing the stomach for cancer. If you're not super careful when you're dividing that ligament, you can accidentally cut off the blood supply to the spleen.
Just collateral damage.
Exactly.
Yeah.
Or, the other way around, if you're removing the spleen and you get too aggressive with your clamps on those short gastric vessels, you could burn a hole right through the stomach wall.
Wow. So you could cause a gastric perforation just trying to get the spleen out?
It happens. It's a mess.
Yeah.
But the real danger, the one that, keeps surgical residents up at night, that's in the back, in the leonorenal ligament.
The posterior one. Why is that the danger zone?
Well, the leonorenal ligament connects the splenic hilum to the left kidney. It holds the main splenic vessels, the artery and vein. But nestled right inside that ligament, often physically touching the hilum of the spleen, is the tail of the pancreas.
The tail of the pancreas is just hitching a ride over to the spleen.
It is. It stretches way out to the left. And this is the classic exam question and the classic surgical mistake. Picture it. You're in trauma surgery. There's blood everywhere. You can't see perfectly. You're trying to clamp the splenic vessels to stop the bleeding. You throw a clamp on.
And you catch the tail.
You crush the tail of the pancreas in your clamp.
And that's bad.
It is catastrophic. The pancreas is full of enzymes designed to digest a steak. You crush it, those enzymes leak out. You get a pancreatic fistula. The patient starts, literally digesting their own insides.
Oh, that's horrible.
Leads to abscesses, sepsis, long hospital stays. It's a disaster.
So the tail of the pancreas is hiding in that posterior ligament like a sniper. That's a huge mental anchor.
Visualizing that tail just sitting there, waiting to be injured, that's step 1 of a safe splenectomy. You have to peel it away gently, respect the tail.
Okay, let's just touch on the plumbing itself. The splenic artery, it's not a straight line, is it?
No. It's famous for being tortuous. It looks like a corkscrew. It comes off the coeliac axis and runs along the top of the pancreas.
Any reason it's so curly.
It allows the spleen to move and expand without putting tension on the vessel. It's like an old telephone cord.
And the vein.
The venous drainage is key to understanding liver disease. The splenic vein runs behind the pancreas. It meets up with the superior mesenteric vein, and together they form the portal vein, which goes into the liver.
So that's why liver problems mess with the spleen.
Exactly. It's a direct plumbing line. If the liver is hard and scarred, like in cirrhosis, the blood can't get in. It hits a wall. So it backs up down the portal vein, into the splenic vein, and the spleen just swells up.
Congestive splenomegaly.
It's purely hydraulic.
Okay, time for a quick check-in. Listener, let's see if you're with us on the anatomy. The question is, if I'm a surgeon taking out a spleen, which ligament hides the tail of the pancreas, and why is that so important to remember?
Think back to the curtain. Front and back?
Got it. It's the leonorenal ligament, the posterior one. And it matters because if you pinch that tail, you can cause pancreatitis or a fistula. Don't pinch the tail.
If you remember nothing else from this section, just remember, respect the tail.
All right, moving on. Section 2. Physiology. We know where it is. We know what it's connected to. What does it actually do? You called it the 5-function factory.
It's a very busy organ. But before we get to the functions, you have to understand the architecture inside. It's split into 2 types of tissue, white pulp and red pulp.
Sounds like something out of a Dr. Seuss book.
It does. The white pulp is basically lymphoid tissue. It's the immune center where antibodies get made. But the red pulp is the filter. And this brings us to our next big metaphor, the turnstile. Or you could call it the culling.
Walk me through the culling. This is how it inspects the blood cells.
Exactly. The red pulp is made of cords and venous sinuses. The blood flows into the cords. But to get back out into the bloodstream, a red blood cell has to pass a physical fitness test.
A fitness test?
It has to squeeze through these tiny little slits in the wall of the sinus. The slits are about 2 to 3 microns wide. A healthy red blood cell is 7 microns wide.
So it has to completely deform itself.
It has to fold up, squeeze through like a contortionist, and then pop out on the other side. A young, healthy red cell is flexible. It's a biconcave disc. It slips right through.
But if it's old or sick?
If it's old or stiff or misshapen like in a disease called spherocytosis, it can't make it. It gets stuck in the slit.
And what happens when it gets stuck?
The bouncers are waiting. The macrophages, they sit right there at the slits. If the cell struggles, the macrophages just gobble it up. That is the culling process. It's quality control.
Brutal. Okay, so that's the mechanism. The text gives us 5 specific functions. You have an acronym for this, IFPRC.
Let's break it down. I is for immune. The spleen is a major factory for IgM antibodies. But even more specifically, it makes these molecules called tufsin and propertin.
Tufsin and propertin, those are opsonins, right?
Yes. Think of opsonyms as buttering the toast. Certain bacteria, especially encapsulated ones like pneumococcus, have a slimy shell. Immune cells can't get a grip. The spleen coats these bacteria in tufsin and propertin. It butters them up so the macrophages can grab them and eat them.
So without a spleen, your body is sort of blind to these slippery bacteria.
That's a perfect way to put it, yes.
Okay. F is for filter.
Which is the culling process we just talked about,
Right.
removing old platelets and red cells. And it's also a recycling plant. It strips the iron out of the dead red cells and sends it back to the bone marrow. Very efficient.
P is for pitting. This sounds like a mechanic's shop.
It is. It's the repair shop. This is amazing. Sometimes a red cell has a little inclusion inside it, a bit of leftover nucleus called a Howell jolly body, or maybe a malaria parasite. The cell itself is fine, though.
So it doesn't want to destroy the whole thing.
Right. So the spleen can actually pit it out. It plucks out the bad bit without destroying the whole cell. The membrane reseals, and the cell goes back to work. It's microsurgery.
That's incredible. Okay, R is for reservoir.
In animals like horses, the spleen is a huge blood bank. They get spooked, the spleen squeezes, and they get this big boost of blood to run away. In humans, it's less dramatic, maybe 8% of the red cell mass. But if the spleen gets really big, splenomegaly, that reservoir function goes into overdrive. It starts hoarding blood cells.
Which leads to low counts in the rest of the body.
Exactly. And finally, C is for cytopoiesis.
Making blood cells.
The spleen does this in the fetus. Then the bone marrow takes over. But, and this is the cool part, if the bone marrow fails later in life, like in a disease called myelofibrosis, the spleen can wake up and start making blood cells again. It remembers its old job.
It's like a backup generator.
Precisely.
Okay, check-in question number 2. Listen up. If you look at a patient's blood smear and you see these little dots called Howell jolly bodies inside the red cells, what does that tell you about their spleen?
Think about that repair shop.
It means the repair shop is closed. The spleen is either gone, surgically removed, or it's not working, what we call functional asplenia. The Howell jolly bodies aren't being pitted out.
Spot on. If you see those, that patient is effectively a splenic, even if the organ is still inside them.
All right, let's move to section 3. Congenital quirks. The hidden spleens. I found this part amazing. Baily and Love says 10 to 30% of people have more than one spleen.
It's surprisingly common. We call them splenunculi. Accessory spleens.
Splenunculi. Sounds like a pasta.
It does. They're usually small, like little nodules of splenic tissue. Half of them are right at the hilum of the main spleen, but the other half can be hiding near the tail of the pancreas or in the omentum. They can be anywhere.
Why does a surgeon care? If I'm taking out a spleen, what's one little extra nubbin left behind?
Oh, you care a lot if you're doing the surgery for a hematological disease like ITP.
That's the one where the spleen eats all the platelets.
Exactly. The spleen is the enemy. So let's say you take out the main spleen to stop it from destroying platelets, but you miss a little splenunculus hiding behind the pancreas.
What happens?
That little accessory spleen realizes the big boss is gone. It undergoes hypertrophy, it grows, and eventually it takes over the job of destroying platelets.
And the disease comes back.
The disease comes right back. The platelets drop again. So if you're operating for ITP, you have to go on a treasure hunt. You have to meticulously check all the common hiding spots. If you don't, you haven't cured the patient.
Let's briefly touch on cysts.
They're rare, but they happen. You could have true cysts, which are congenital, or pseudocysts, which are usually from old trauma or pancreatitis, and then you get hydatid cysts from a parasite. Those can be tricky.
Okay, on to section 4. This is the real bread and butter of emergency surgery. Trauma, the fragile organ.
It is the most commonly injured intra-abdominal organ. I mean, think about where it is, right under those left lower ribs. It's soft, it's full of blood, and it has this very thin capsule. It's like a water balloon.
It's a big hit on the left side, a car crash, a fall.
A cyclist going over the handlebars is the classic one. You have to assume a splenic injury until proven otherwise.
And we grade these injuries. Table 70.1 in the book. It goes from grade 1 to 5. Can you break this down for us? It's all based on the CT scan, right?
Right, CT is the gold standard. So grades 1 and 2 are minor. Think of a bruise, a subcapsular hematoma, or a shallow cut, a laceration. These almost always heal on their own.
And grade 3.
Grade 3 is where things get more serious. The hematoma is bigger, maybe ruptured through the capsule. The laceration is deep, right into the meat of the organ.
Okay, so grades 4 and 5 must be the really bad one.
This is where the pucker factor kicks in for the surgeon. These are vascular injuries. Grade 4 means a major blood vessel inside the spleen has been damaged. A big part of the spleen has lost its blood supply.
And grade 5.
Grade 5 is the shattered spleen. It's just pulverized. Or the main vessels at the hilum, the main artery or vein, are torn. The plumbing is disconnected.
Okay, so we have the grade. How do we decide what to do? In the movies, they just rush to the OR and take it out.
That used to be the mantra. When in doubt, take it out. But we've learned how valuable the spleen is, especially for immunity. So the thinking has completely shifted in the last couple of decades.
How so?
The decision tree is simple now. Is the patient hemodynamically stable?
Meaning, is their blood pressure okay?
Right. If their blood pressure is holding, if their heart rate is fine, even with a nasty-looking grade 3 or 4 injury, the plan is to conserve. We call it NOM, non-operative management.
So you just watch them.
We watch them like a hawk in ICU. Serial blood tests.
Yeah.
And we have another tool now, which has been a game changer, angiography.
Tell me about that.
If we see active bleeding on the CT scan, we can send them to interventional radiology. They can go in through an artery in the leg, thread a catheter all the way up into the splenic artery, find the bleeder, and plug it with coils or glue. Embolization.
You fix the leak from the inside without ever opening the abdomen.
And you save the spleen. It's brilliant. But, and this is a huge, but if the patient is unstable, if their blood pressure is crashing, you have no choice.
Then it's to the OR.
You go to the OR. Life over spleen. Every time.
Let's run a quick case study here, a fictional one. A 25-year-old cyclist hits the handlebars. Left upper quadrant pain. CT shows a subcapsular hematoma covering about 30% of the spleen. No active bleeding. His BP is stable, 120 over 80. What's the grade and what do you do?
Okay. Subcapsular hematoma, 30%, that's a grade 2. The key is his blood pressure. He's stable.
So
the plan is NOM, non-operative management. We admit him, strict bed rest, watch his hemoglobin. We do not rush this kid to surgery. We want to save that spleen so he can fight off bacteria when he's older.
But there's a catch with trauma, isn't there? This idea of a ticking time bomb.
Delayed rupture. It's a classic concept. The idea that a hematoma forms, it stays contained for a few days, and then boom, it bursts.
Does that really happen?
Modern data says it's rarer than we thought, except in one specific situation that Baily and Love points out. Malarial spleens in the tropics. A malarial spleen is big, soft, boggy. It's incredibly fragile. Even a tiny bump can cause a hematoma, and because the capsule is so stretched, it can rupture days later. So you have to be much more cautious with those patients.
Got it. Okay, section 5, splenomegaly and hypersplenism. First, what's the difference? People use these terms interchangeably.
And they shouldn't. Splenomegaly is simple. It's a physical description. The spleen is big. That's it. Remember, it has to be 3 times normal size to even feel it.
And hypersplenism?
Hypersplenism is a syndrome. It's a functional state. You need 3 things. 1, a big spleen. 2, low blood counts anemia, low white cells, low platelets, because the big spleen is either eating them or hoarding them.
And 3?
3, a bone marrow that's working overtime trying to compensate. And the 4th unofficial criteria is that it's all cured by taking the spleen out.
Okay, so why does it get big? The book lists a ton of causes.
Let's bucket them. First, infective. Globally, malaria is king, but also things like Kala-Azar and TB. Second, congestive. This is just clumping. Portal hypertension from liver cirrhosis is the big one here. The blood backs up.
And the third bucket?
Hematological. Blood disorders, leukemia, lymphoma, and the ones we operate on, like spherocytosis and thalassemia.
Let's do another case study on that. This feels like a classic exam question. A 6-year-old child comes in. Mildly jaundiced, anemic, and you can feel their spleen. The dad mentions he had his gallbladder out when he was 20.
Ding, ding, ding. That is a textbook presentation of hereditary spherocytosis.
Connect the dots for us.
The child has a genetic defect in their red blood cell membrane. This makes the cells leaky, and they swell up into a sphere instead of a flat disc.
And spheres don't fit through the turnstile.
Exactly. They get stuck in the red pulp, the macrophages eat them. That causes the anemia. The massive breakdown of red cells releases bilirubin, which causes the jaundice. And all that extra bilirubin forms pigment gallstones.
Which is why the dad had his gallbladder out so young.
That's the huge clue. A young person with gallstones, you have to think about hemolysis. So the kid has it too. The cure is a splenectomy. You remove the filter. The cells are still spheres, but now they don't get destroyed.
So why wait until they're 6?
Because the spleen's immune function is so critical in those first few years of life. We want to reduce the risk of overwhelming infection. So we wait as long as we can, give them folic acid, and then do the surgery.
And you check for gallstones before you operate.
Always. With an ultrasound.
Right.
If they're there, you take out the gallbladder at the same time.
Smart. Let's quickly go back to ITP in section 6. The core problem there is what?
ITP is autoimmune. The body makes antibodies against its own platelets. The spleen sees these antibody-coated platelets and clears them out.
And surgery is the cure?
It can be.
Oh.
We try steroids first. But if that fails, a splenectomy cures about 2/3 of adult patients. And it's perfect for laparoscopic surgery because at ITP, the spleen is usually a normal size.
Contrast that with sickle cell disease. The spleen does something totally different there.
It does. In sickle cell, the rigid sickle-shaped cells block the tiny blood vessels inside the spleen. This causes lots of little infarcts, little strokes in the organ. Over time, the spleen just scars down and shrivels up into a tiny, non-functional nubbin.
It performs its own splenectomy.
Exactly. We call it autosplenectomy. So an adult with sickle cell is functionally a splenic and needs all the same precautions.
Section 7. The operation. Splenectomy. Open versus laparoscopic. When you do an open procedure,
You go open for the really massive spleens or for major trauma where you just need to get in there fast. The key surgical move is to get your hand behind the spleen and roll it up and towards the
you're in
median.
the pancreas tail with it.
Bringing the pancreas tail with it, which you then have to carefully dissect off.
And laparoscopic.
That's the gold standard now for most elective cases. We put the patient on their right side so the spleen sort of hangs down by its ligaments. It gives you a beautiful view of the hilum. You use a stapler to divide the vessels.
But then you have a whole organ inside the belly. How do you get it out through a tiny hole?
You put it in a special strong plastic bag inside the abdomen. Then you use an instrument to break it up inside the bag morcellation. Then you just pull the bag out.
Like a ship in a bottle, but in reverse.
Exactly.
But before any of this, you have to prep the patient. The triple shield.
Non-negotiable.
Mm-hmm.
You are permanently compromising their immune system. So you have to vaccinate against the 3 big encapsulated bacteria.
Which are?
Pneumococcus, meningococcus, and Hib, Haemophilus influenza type B.
And the timing is key.
Absolutely. Ideally, you give the vaccines 2 weeks before an elective surgery, so the body can mount an immune response while the spleen is still there to help. In an emergency, you give them as soon as you can afterwards, usually before they go home.
Plus antibiotics.
Yes. Daily penicillin. For kids, usually until they're at least 10. For adults, for at least a few years post-op.
Which brings us to our final section, number 8. The aftermath. Post-op complications. Let's start with the immediate stuff.
Well, you can have bleeding from a slipped ligature, which is a surgeon's nightmare. You can get pancreatitis if you injured the tail. And atelectasis is a very common collapse of the base of the left lung because it hurts to breathe deep.
And what about thrombocytosis?
Right. The spleen normally gets rid of old platelets. You take it out, the platelet count can shoot up over 1 million. That increases the risk of blood clots, so you have to be vigilant.
But the big one, the one everyone is terrified of, is OPSI.
OPSI, opportunistic post-splenectomy infection. Some people call it overwhelming post-splenectomy infection. This is the silent killer. It's rare, but the mortality is incredibly high, up to 50%.
And it can happen fast.
Frighteningly fast. A patient without a spleen can go from feeling a little bit off to full-blown septic shock and death in 12 to 24 hours. The bacteria just multiply unchecked in the blood. Pneumococcus is the #1 culprit.
And this can happen years later.
Decades later. You are never safe.
Yeah.
Which is why patient education is literally life-saving.
So what do you tell them?
1, wear a medic alert bracelet that says splenic. 2, if you ever get a fever or chills, that's an emergency. You start antibiotics immediately and you go to the hospital. Don't wait.
Oh.
And 3, Be very careful with animal bites.
Animal bites. Why?
Specifically dog bites. There's a bacteria in dog saliva called Capnocytophaga canamorsis. In a normal person, it's usually no big deal. And in a splenic patient, it can cause a ferocious fatal sepsis. It hits them like a freight train.
Wow. Okay, final check-in question. A patient had their spleen out 10 years ago. Today, they get a small bite from a dog. They feel fine. Why are we worried?
We are worried about Capnocytophaga and OPSI. Even if they feel fine now, that bacteria could be multiplying. They need antibiotics right away. The window to treat this is tiny.
That is a life-saving piece of information. Okay, let's wrap this up. We have covered a huge amount of ground.
We really have. We mapped the anatomy, remember the apron strings and the dangerous pancreas tail. We toured the factory, the 5 functions, IFPRC. We graded the trauma and talked about why we now try to save the spleen. We looked at the big spleen diseases like spherocytosis, and finally the life jacket, the vaccines and antibiotics to prevent OPSI.
My big takeaway is that the spleen is not some disposable organ. It's a really sophisticated piece of machinery that we should fight to keep. So here's your call to action. Go open Chapter 70. Look at the diagrams of the hyaline. Look at the CT scans. You need the visuals to cement this.
Absolutely. We gave you the framework. The book has the fine print.
And I want to leave you with one final provocative thought. The chapter briefly mentions something called splenosis. Basically, if a spleen is shattered in trauma, little bits of it can seed themselves around the abdomen and regrow into tiny functional spleens.
It's nature's attempt at an autotransplant. The body knows it needs that function back.
Exactly. So if the body tries so hard to regenerate this tissue, and if our surgical practice is moving more and more towards saving the spleen in trauma, are we approaching a future where a splenectomy for trauma becomes a historical procedure? Will we look back in 50 years and say, can you believe we used to just cut those things out?
It's a fascinating thought. For trauma, maybe we're getting close. For cancer and the big hematological problems, probably not.
Yeah.
But the trajectory is clear.
It is. The body is resilient, and surgery is always evolving. Thank you for joining us on this deep dive into the spleen. Good luck with your revision.
Read the chapter. We'll see you next time.
Bye for now.